Anytime you actually have someone complaining of a bite-sensitive tooth and you use something like the tooth sleuth and they actually put pressure and there's pain upon pressure upon release, one of the first things that you think of is that, yeah, there might actually be a fracture in the tooth. There is a huge range of how people describe pain, and I always say that there are a little more sensitive people, and so sometimes you've got to take everything that they say with a little bit of a grain of salt and kind of factor that into what's going on as well. Statistically speaking, overall, if the root canal is done properly, success rates are in the 90 to 95% range.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists. This is episode number 179. My name is Andrew.
And my name is Michelle. Welcome back, everyone. So I did want to give a big thank you to everybody who reached out and for their well wishes after my surgery. I really do appreciate you. I got lots of cards and texts and DMs and all that kind of stuff. And I really do appreciate you guys. So thank you.
Yeah, people do miss you and they actually do like you, even though you think that no one does.
I just said I'm unapproachable, which has been proven on this podcast. You're the approachable one.
Well, they know this podcast would fail without you, so.
Well, we're a good team. Yeah, the one thing, though, and I think I might have said it on this one, though, and I've talked in the past about mental health and how I'm really kind of getting into that whole side of the whole body wellness. We're talking sleep apnea, we're talking obstructive sleep disorders, and we're talking overall health. But one thing I think that does not get a lot of attention is mental health. And I swear, I think every person should be talking mental health after surgery, because complete transparency, it kicked me in the butt this week. Not being able to exercise, not being able to do my normal thing, not being able to produce the things that I produce every day, which you mentioned that I'm a much more high productive human, which I don't think is completely true, but
at least public facing. I mean, the Michelle that I know is someone that's a go, let's get all this stuff knocked out. Hey, Michelle, what are you doing? Well, I have these 3 things on the burner right now, but what else do you want me to do, Andrew? And so you do that. That's what you do. So I think it's kind of hard for you to step back and be calm for a minute with your thoughts.
It's very hard. Yeah. But my friend brought up a really good point. She took me to the beach. We walked the beach because I'm supposed to be walking a lot, which was great. And, I went through my coffee detox in the hospital with the most annoying caffeine headache that narcotics couldn't take care of. Caffeine withdrawal is real, y'all. And I've gone through my wine detox, but it's almost like you have to go through a mental detox as well and slow yourself down and learn to relax and accept the lows, because then you'll really start to appreciate the highs once you come out of it. So I appreciate her for that perspective, because I was like, I think I'm going to need medication. If I can't go another day in this house on this couch where I need a nap, I can't produce anything past like 2 hours, and then I'm exhausted. Like, I'm going to need some Zoloft stat. That's the case. But it's much better. Today's much better. I'm really happy. And I'm excited that we were able to do some podcasting, but you're not feeling too good.
Yeah, I don't know. It's that sinus headache, I think, from allergies and all that stuff. But my mistake, I actually took some medication for it. Look, I know that I have an addiction to caffeine, and like we all know, I love my Red Bulls, and that's my but any other medication, like Red Bulls doesn't hardly touch me at all. It makes me feel nice and I'm okay. But other medications like knock me on my butt or do absolutely nothing to me. It's very, very weird. So I took one little bit of my decongestant, Sudafed, something. I don't
a Benadryl-ish, something like that, antihistamine.
All day long, I've been out, and I've been even now, I'm like, oh, this is like pretends land. Like, I'm going to wake up any moment and be like, oh, good. We got like 5 podcasts knocked out that day. Did I? Oh, I wonder where I was for that. I wonder what I said. So interesting.
Well, I hope you get past that soon because that fog is no fun.
Well, I have to be at work tomorrow, so let's just sleep it off. It'll be fine.
We also want to tell you guys about a really great offer from Zerk. How many times can we say how much we love the Crystal HD mirrors? And we both use them. And I don't know that I could go back to another mirror at this point.
No, it's really interesting, though. This week, my doctor and I were talking about at what point do the cracks in a tooth indicate that we're going to need to do like full coverage crowns or onlays, inlays, and things like that. And so he, as part of our education, we were sitting down doing pictures, and I could see one of them was exactly the Zerk Crystal HD mirror that I have in my setup. I'm like, oh, how about that, doctor? Look at my cool mirrors. They're everywhere now.
Yeah, and it's one of those things too when somebody like takes your kit or something where you have the good mirrors and the good instruments. You're like, those are like fighting words. Those are fighting actions. I will see you in the parking lot. But if you only have one or two, this is the opportunity to get more because you can get $7 off a 12-pack of Crystal HD mirrors if you use the code TALEHD. So TALEHD. So don't miss out on that. Get yourself some more, or maybe get yourself a refresher set and enjoy that code from Zerk.
But what I'm really excited about, though, FYI, is that today's episode is going to mark the beginning of like a mini series. What do you call that? Like we had a mini series.
Yeah. Well, I don't know if you guys have noticed, but we've been really making an effort to put our content into series and kind of group them together a little bit so that they can build on each other. And we hope that you enjoyed the Cardiology series last month. And, we started the year out with a major one, which was the Airway series, which was just
perfect. So we were really trying to lump them together, and we started this series with Endo. So we have Dr. T.R. Ravenel on the podcast. I actually work with him at my outreach center. He is a professor and faculty member at MUSC, the Medical University of South Carolina. And so we're going to talk endo, which is not something we talk about as hygienists. I mean, we might be like, oh, yeah, there's a periapical lesion, but do we know?
I would say before you guys turn us off real quick, because you're like, oh, no, endo. Like assistants hate having to sit through endo procedures because it's so boring. This is going to be something that you can really apply to your day-to-day. So the whole idea with this series is what kind of conversations can we have with our patients to make them understand the importance of specialty procedures, and so they don't run for the door and never come back and never get those procedures done. And then also what kind of communications can we have with our doctors and the specialists so that we are educated enough to have those types of conversations. So there's a lot of really cool stuff in here that's not so much dry and procedural, but there's also some procedure stuff as well.
Yeah. And the one day that I was like, we need to have a podcast on this, because Dr. Ravenel walked in and I was like, I think there's a crack on this tooth. I mean, it's just pretty indicative with the probing depth. And he was like, oh, is it like a J-shaped lesion or whatever? I was like, what? On the what? I was like, I don't know what you just said to me. I know clinically what I have known about cracked roots. So it was really great to have Dr. Ravenel on the podcast. And we hope you enjoy the first part of the series.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So listeners, I'm excited because I'm bringing in a dentist that I actually work with at Our Lady of Mercy, the outreach program. And I've actually worked hygiene, and then you guys are doing endo next to me. And it's really fascinating because that's not an experience I've ever had as a clinician. I've been so far removed from endo. So we just want to welcome you to the podcast, Dr. Ravenel. If you could tell us a little bit about yourself.
Well, thank you. Yeah, it's been a pleasure to work beside you. You've always got a smile on your face, and you always got a positive attitude. And so, like I say, I always...
See, Andrew?
Who is this person that you work with? Because this is not who I know.
But it's been a pleasure, and actually, that clinic has been a blessing. It's y'all have got a great thing over there, and it's great to be part of it. For me, I'm a South Carolina native, born in Columbia, South Carolina. I went to USC for my undergraduate, and then actually went to the medical university for my dental school training. After that, I did a 2-year general practice residency, and then went up to Maryland for my endodontic residency. Afterwards, my wife, she's a periodontist. We set up a practice here in Greenville, South Carolina, and until a year and a half ago, I had a practice up that way. And as fate would have it, the guy who taught me endodontics at the medical university ended up retiring, and I ended up selling my practice and was able to take over his position down there. So it's been, these past couple of years have been a fun time. But right now, my official title is like assistant director of the postgraduate endodontic program. Truthfully said, I'm kind of the jack of all trades. So I'm whatever they need me to be as far as undergrad, grad. It's all good to me. I'm just happy to teach people how to do endo. And like I say, that's the fun part of my job.
So for today, what we were going to talk about, what we wanted you to kind of teach us like you teach your first years or your dental students, right? Like even looking at radiology, because like we mentioned and talked on the phone, like we don't really get a lot of that in school. Like, Andrew, would you agree? We talk about endo when we're like looking at like maybe in radiology. We talk about it a little bit as far as like diagnostics, what an abscess is.
And that's pretty much it after that. Yeah. That's
pretty much it. Yeah. Everything else we would learn from going into an office and working with people. So don't feel like you're being, you're giving us information that's like, oh, they should already know that, or I don't want to sound condescending. We'll take it. And we have a lot of new grads and also students that listen to our podcast.
Well, that sounds perfect. When you first started to kind of talk about that, as far as what I know, and, granted, you're probably one of the few hygienists that I talk to on, a regular basis. But, to me, in my mind, I'm not really sure why they don't emphasize that more in y'all's school settings, just from the standpoint of, in my private practice experience and even down here at MUSC, I guess what I run into most of the time is that patients come in and they say, well, I had a, hygiene appointment set up. I had a problem, but I knew I had that coming up. So I was waiting to see them before I said anything. And so most of the time they're going in there with a problem. And so you're kind of, you have to do one thing, and then you've got to be a diagnostician and kind of figure out kind of what's going on at the same point.
Absolutely. You're so right. Well, let's talk about that. I would love for you to say that. And also, we can, again, reiterate why we think that this podcast episode is really important, because we are just kind of learning it in the moment within the clinics. And it would be nice, because you said to me one time when I was like, I think it's a fracture on a tooth. It's pretty indicative signs of like, a sudden 7 millimeter pocket on the distal buccal root, just out of nowhere. That's pretty indicative to me that it's a crack. And you were like, well, has it got a J-shaped radiograph? I was like, well, those are details I did not know existed. So let's talk about that.
Well, yeah, I guess kind of when you have a patient come in, you always kind of have to approach everything from a logical kind of standpoint. And the best way that I explain it to the dental students when they come through is, imagine you're Dr. Spock. He's a very kind of, you approach everything in a logical manner. You have an algorithm for how you kind of go down kind of the chain of what you're dealing with. The first thing that I always do, of course, is ask the patient what their chief complaint is in their own words. Really see what they're saying. Then after that, you're going to be asking kind of probative questions as far as, kind of, you're having discomfort. Is there pain associated with it? How long have you been having this? Is there, we'll say, kind of any stimulus to the pain? Is it hot or cold sensitive? Is it bite sensitive? All those things kind of come into play as far as trying to narrow down kind of what you're actually looking for. You also kind of want to take into consideration kind of the level of pain, the discomfort that they're dealing with. Most of the time people use some type of visual analog scale just to kind of get an idea of kind of the severity of what they're kind of going through. And of course, I always kind of review their medical history, make sure there are no changes that would impact anything that we do. From there, the way that I approach it is just point to where the problem is. And normally the patients, have a fairly good idea. They're able to kind of at least narrow it down to a region. From there, we can kind of get our exam going clinically to kind of see, what's actually going on. I kind of have a systemic approach as far as after we do kind of our extraoral and intraoral exam. The first thing I always like to do is just percussion. So typically we grab just a mirror handle. We just kind of lightly tap, if we're doing anterior teeth, just the incisal edge, posterior teeth, just the, light tap on the actual cusp tips. If a patient is in extreme pain, that's the worst thing you'd want to do. So typically you just grab your finger, kind of lightly tap on those teeth. The worst thing you want to do is kind of send them jumping out in the chair. But that's kind of just a general way to kind of narrow down to if it is a tooth problem or not. After that, I like to palpate kind of the area, kind of knowing where the root apex ends. That way you can kind of, if you're going to have a problem and it's going to be an endodontic problem, you're going to typically have the inflammation starting kind of, at the apex before any other area. So a lot of times, even if the tooth isn't percussion sensitive, it might be palpation tender at the apex of the tooth. Of course, you would check mobility. If the patient is complaining of a bite tenderness, typically you would want to grab, something like a tooth sleuth or a Q-tip or a cotton roll and have them kind of occlude on different teeth to see if you can kind of reproduce that pain. Anytime you actually have someone complaining of a bite-sensitive tooth and you use something like the tooth sleuth and they actually put pressure and there's pain upon pressure upon release, one of the first things that you think of is that, there might actually be a fracture in the tooth.
So I think we have two questions, if we could just interject for a minute. I know, Andrew, you do, but can we explain what a tooth sleuth is for some people who don't have any clue? If they've never even heard that word.
Yeah, so it's basically like a plastic stick, and it has kind of a cupped out region corresponding to where the cusp tip actually could kind of fit. And so you actually have them kind of, it's like I say, literally just like a plastic stick that you can place on the opposing cusp tip. The patient can then bite down and then release. And then if there is any type of fracture or pain associated with release or pressure, then typically that is associated with some type of fracture line or crack line in the tooth. If you don't, then you kind of move on to the next cusp tip and kind of try each one. Most of the time, the older an individual gets, the more prone they are to kind of wear and tear of teeth. And so therefore, then, like I say, you can have a crack line, and usually it's kind of confined to one or more of the cusps. So it's easy to identify kind of a problem tooth by that.
So, Doctor, when you're doing the percussion, you mentioned you kind of go onto the incisal edge of the cusp tips, or what if there was a kind of a lateral pressure as opposed to like the occlusal force pressure? Does that change any diagnostics at all?
No, not necessarily. Yes, I do sometimes, usually just kind of straight up and down is the easiest way to go through there. But yes, every now and then I will kind of go back and do it laterally, like you say. And so that is a good recommendation to kind of try a varying angle. Most of the time when I'm having kind of a situation where I can't really narrow it down, those are usually the harder ones to diagnose. And what you find is that with a fracture per se, you almost have to hit it at the right angle in order for it to really kind of mimic the pain that the patient is feeling. So that's where, kind of like you're saying, more of a kind of a lateral pressure sometimes might allow you to kind of see what's going on.
Can I go back to, you said what the level of pain, you kind of refer to it as like an analog. Is that really like a scale of 1 to 10? Like what level?
Yeah, normally, like in the hospital, I think at MUSC, they have those little smiley face emojis that, you kind of rate. Those always kind of crack me up. But I say that with the asterisk at the end of the sentence because y'all know more than anything, there is a huge range of how people describe pain. And I always say that there are a little more sensitive people. And so sometimes you've got to take everything that they say with a little bit of a grain of salt and kind of factor that into what's going on as well.
I was more curious about like referred pain too, because you said to have them point to the pain. And how often do they have any kind of referral pain?
Studies have actually shown us that the patient is able to discriminate the pain that they feel most of the time, around anywhere from 50 to 70 to 80% of the time. Now, it depends on kind of if they have periradicular inflammation. And by that, I mean, does the tooth actually hurt when they bite, or they actually put pressure on the tooth? So if you have kind of those signs and symptoms present, usually the patient is actually fairly good at kind of narrowing down the area. In situations where there is no bite sensitivity or no percussion sensitivity, that sometimes is where it becomes a little more vague. You can have referred pain. In those situations, it actually you kind of need to know which teeth can refer to what area. And in general, you can have, it's typically the maxillary molars can refer to the lower molars, and you can have the lower molars referring to the upper molars. That's kind of the general rule of thumb. Every now and then you'll get some crossover where you'll have, a premolar do the same thing as well. But normally, like I say, it's more the molars that you'll find that. That really depends on kind of how the actual pulp of the tooth is diagnosed. The easiest way for y'all as far as hygienists, and I think that would behoove the dentist that you work with, is to educate y'all on doing cold testing, because that really is the gold standard to really figure out kind of the actual pulpal status of the tooth that you're working on. Typically, you just have endo ice, which is just tetrafluoroethane. Overall, like when you spray it on a little cotton pellet. It's roughly about minus 26 degrees Celsius. When you put it on the tooth, y'all are aware with, dealing with dental hypersensitivity on a daily basis. Basically, what happens is you have fluid movement in the tooth, which elicits pain. So what we're trying to do when we do a cold test is to move that fluid to see if we can mimic the pain that the patient comes in. So if you have a patient who comes in and says, hey, my tooth is sensitive to cold, you would cold test one tooth, and then you would, to kind of get a baseline, and then you would test the tooth in question and see if you have either an exaggerated response or no response, or, like I say, a normal response. And that helps you actually come up with a pulpal diagnosis for whether the tooth needs any type of endodontic treatment, or if it actually just needs something like a restoration or, decay removal, something along those lines.
So what would be a normal response? What are we expecting for healthy teeth?
Typically, what I would say to the patient is we're going to put a piece of, a little piece of cotton with some cold on the tooth. As soon as you feel anything at all, we want you to raise your hand. The normal response for most patients is they'll feel it within about 3 to 5 seconds. And then we want them to keep their hand up until that sensation dissipates and then lower their hand. And for the average response, you feel it fairly quickly. It typically, once you remove it, once they raise their hand, remove the cotton pellet, and then their hand typically will go down within 3 to 5 seconds. And that would normally be a normal tooth. From there, if the pulp is actually inflamed, say if we had a moderate to a small size carious lesion, or if we had a leaky restoration, if you get into a situation where we have bacteria, and they're basically causing inflammation to the nerve, but basically you put the cold on there and all of a sudden, bam, they feel it a lot quicker. You have an exaggerated response. The key, though, is that the response still goes away in a quick time frame. So they'll put their hand up almost immediately. They'll say it's a lot stronger, but then actually, the time frame, the duration still goes away within 3 to 5 seconds. That is actually what's considered a reversible pulpitis. And typically in those situations, you just, find the cause and you take care of it by, like I say, most of the time it's either a leaky restoration or some type of decay on the tooth. From that point on, it actually starts to get into worse scenarios. So say if you didn't do anything to that cavity, well, of course, that cavity is going to progress, get closer to the pulp of the tooth. The pulp will become irreversibly inflamed. And at that point, it becomes an irreversible pulpitis. Those situations, you can have actually an asymptomatic irreversible pulpitis. And those are the patients where that come in and they've got some massive hole in their tooth. And you're like, how in the world is this not bothering you? But
yes.
What we find in those kind of crazy situations is that there are certain bacteria that have an attendant effect on the actual pulp tissue of the tooth. So they can literally eat a hole in it. The nerve, basically, for all intents and purposes, is irritated, but it doesn't respond the way that you think it should. And if you were to put cold on the tooth, actually, it might respond normally. Now, in those situations, the decay is all the way into the pulp tissue. You still would have to do a root canal. The most common one, though, that people run into where they're having pain, though, is the symptomatic irreversible pulpitis. And that's where you put the cold on the tooth and literally their hand shoots up. The pain does not go away. It lingers, it throbs, it aches afterwards. And of course, that's kind of a whole different ballpark. Those typically you're left with either, obviously in the asymptomatic irreversible pulpitis, you're kind of in the same two options of doing root canal or taking the tooth out. Same thing with asymptomatic irreversible pulpitis. You have to either do a root canal or take the tooth out as well.
So the symptoms, doctor, for a cracked tooth versus a symptomatic irreversible pulpitis, would they be similar or would they be different?
Well, it depends. So in the beginning stages of a cracked tooth syndrome, you're going to basically have, bite sensitivity. Now, if, you're able to reproduce that, they might have, when you use your tooth sleuth or cotton roll, when they bite down, you might have pressure when you bite on the tooth. But you can have a situation where the pulp is just reversibly inflamed. So you would still go do your actual cold test, and based on whether the patient responds, if it puts his hand up, maybe it's exaggerated, but it goes away quickly, well, that still would be a reversible pulpitis. At that point, you've got to take care of the problem, which is the fracture. So you would actually typically prep the tooth for a crown, put them in a temporary, and see if the symptoms go away. If they do, well, then all you've got to do is put the crown on the tooth and you're good to go. If you cold test it and he is exaggerated, lingering response, throbbing pain afterwards, well, the pulp is irreversibly inflamed. You would need to do the root canal before you talk about doing any crown work. And then, of course, once the root canal is performed, he would come back to the general dentist for the actual restoration.
And if the fracture extends down below into the root surface, it'd have the same symptoms as a crack that it's above, like just in the coronal portion?
Typically, yes. There are situations where, depending on how long the tooth, the crack actually has been there, you can have other signs and symptoms. But for the most part, most people, they present differently in each scenario. So it's hard to say necessarily, is it going to be this way or that way? Sometimes what you find is that a patient will come in and say, well, the tooth was sensitive to bite months ago. It then settled down. Those are kind of the ones that you worry about because, the situation has moved from maybe an irreversible pulpitis where all of a sudden now we're looking at the crack has gotten worse. It's going down below the gum line. Now the actual pulp of the tooth has died and it has become a necrotic tooth. And so then you kind of have to worry about kind of different things in that scenario.
How does heat factor into this?
Well, any type of thermal issue, plays a part. Now, what you find is that, people, when they have the initial stages of something going south, normally they'll say it's hot and cold sensitive, depending on what kind of liquids they like to drink. Sometimes people are big coffee drinkers, so they'll say, the hot bothers them more so. What you most of the time find when someone comes in and their chief complaint is specifically heat, that typically means that the pulp of the tooth is almost dead as a doornail. So if hot coffee is the only problem that they're dealing with, what you find is that the pulp actually, if you're to cold test it, most of the time there's no response at all to cold. And what is happening is that the tissue in the tooth is almost degraded, but there are still some what they call C fibers, or basically little nerve fibers in the root of the tooth. These things are able to withstand. They can live in a low oxygen environment. They're very durable. So what you end up finding in those situations is that the heat, what it does is it diffuses through the tooth a lot more so than the cold does, and it actually stays around longer. So in a cold situation where you put the cold on the tooth, well, if you have water in there, you're going to see a response. Well, in a dead tooth, there will be none of that going through because there's really no fluid movement. So if you have a hot sensation and there's really no pulp tissue in the top of the tooth, the heat will diffuse through it and activate these nerve fibers in the root of the tooth, which will cause them to fire. And then, of course, you'll have kind of significant throbbing pain afterwards. But yes, if someone comes in on average and says, I've got heat sensitivity, it's killing me when I drink something hot, usually their tooth is, for all intents and purposes, dead. And you're looking at doing a root canal on it.
So if we percussion, palpation, mobility, endo ice would be ideal. What would those next steps, or is there any other
Well, the other things that you can always do would be the electric pulp test. So say if someone comes in and they don't have a full coverage restoration on the tooth, kind of an easy thing to do would be just to grab your EPT. It's an easy test to do. Literally, you just have to dry off the tooth, find an area of natural tooth structure. It's basically, there are two different types of them. One is a little metal wand that you actually have the patient touch the wand, and then you touch it to the tooth, and it actually completes the circuit where it runs a tiny little electrical current through the tooth. What you're actually looking for is there a positive or a negative result? So if there's living tissue in the tooth, the patient will feel it. I don't know if you've ever been around a horse farm, but if you ever touched one of those little electrical fences, it's like a very minor kind of little stimulus like that. I always joke with the patient, tell them, we're going to ground you, and they always kind of get a kick out of that. But it's an easy test to do. If they feel anything, all they got to do is just let go, and that breaks the circuit. And so therefore you can say, okay, well, we had a positive reading. It doesn't tell you anything about the status of the pulp, but it just tells you whether there's living tissue functioning in there or not. If the electric test went all the way to the maximum value, well, typically that means that something's not right. The pulp is typically necrotic in that situation. And so therefore, fairly consistently, you can tell that, most often you're going to need a root canal in order to fix this tooth or take it out, one of the two. The other type, there's not something that the patient actually touches. It's actually a lip clip, like you sometimes see if you're doing a root canal, and the lip clip actually completes the circuit. Those, if the patient feels it, you would actually just remove the metal probe off the tooth, and that would break the circuit if the patient said, yes, I feel something at that point. But the electric pulp test is a great test to do. Overall accuracy of that is in the range of about 80%. If you get a negative response, then typically, something's not right. You always like to do that in conjunction with the cold test, because if you put those two together, the more things that you have pointing towards a particular tooth, saying that something's not right, then the more accurate your diagnosis actually is. Probing is massive as far as, making sure that we do everything correctly. Y'all are, like I say, experts at kind of looking at, pariradicular structures and making sure there's nothing wrong with that. You mentioned before, as far as kind of an isolated pocket. Whenever you have a tooth that has had a root canal and the patient comes in and they're having discomfort with it, and you probe periodontally around it, and like you said, if you have just an isolated pocket in one little area, you have a previously treated root canal, we always kind of keep in mind, once you do the root canal, most of these teeth are heavily restored, which makes them more prone to fracture. And so typically, most of these teeth have already had MOD preparations. They already have a crown on it. When you do the root canal, of course, you weaken the tooth structure because you're coring out the inside of the tooth. So sometimes a patient can bite down, literally crack the tooth, and unfortunately the crack can go into the root of the tooth. And then subsequently, you'll see radiographically bone loss around that side where the actual crack is. And like you said, sometimes it'll be like an inverted J, which is basically bone loss down the lateral surface of the root, which kind of scoots around the apex. And just like you draw that actual letter, you'll see that radiographically. And those kind of, things are indicative of, like I say, kind of a hopeless tooth that would need to come out. The only additional thing sometimes, which I think is a great thing for y'all to consider doing, would be something like, an anesthetic test. Say if you have a patient who comes in and says, I can't tell if it's coming from top or bottom, I'm just having pain over here. You think it's coming from one tooth, say a maxillary number 3. There's nothing wrong with, if you're not doing anything on that day, as basically just, putting a little local up in that area. If the pain resolves, well, then most likely it's coming at least from that, that quadrant. And that's another little diagnostic tip to kind of help figure out at least, okay, well, at least we're in the right area.
Doctor, just running back to the EPT, you mentioned that you have to have like a live nerve tissue. It's not necrotic to complete that circuit. What if there's like a calcified canal? Is that still technically alive, or will you still get the same responses?
Yeah, it's very rare that you don't get it. There are situations where, it could actually give you a negative response, and the actual tooth does not need a root canal. So there are situations, especially in trauma, where literally if you're to take an x-ray, you do not see any type of pulp tissue at all. The entire tooth is almost, for all intents and purposes, solid dentin. In those situations, you might get a negative response, but that necessarily doesn't mean that you need to do a root canal. Most of the situations that we would be talking about as far as someone in pain, you're going to be able to look at everything as a whole and go through and say, okay, well, we've percussed, we've had, a bite test, we've done the cold test, we've done the EPT, and you can really narrow things down. You're always looking for the odd guy out. So when you go through a diagnostic process, if you have 3 teeth that respond to EPT and 1 that doesn't, well, okay, there's kind of the guy that we're starting to look at as the most likely culprit.
So can we circle back to radiographs and talk about what are some things that we can quickly identify if we are taking a PA or bite wings, of course, wouldn't show us much on periapicals, but what are some things that we can just quickly notice? And then what are some things upon closer looks to the radiograph could we identify?
The way that we always approach it is, and I'm not sure, how each general dentist is going to probably be different, but really the most appropriate way to approach a patient who's having some discomfort in the region, and you kind of narrow it down to a couple teeth, you really want to get 3 PAs. You want to get 1 bite wing because you're just evaluating kind of the crestal bone levels. You're evaluating the kind of the marginal integrity of restorations, see if there's any overhangs or anything like that. And you want to get a straight on periapical. For that, you want to get the entire root in there, make sure that you're looking at the apex, and then you want a shift shot. And so with the shift shot, you're just angling it roughly 10 to 15 degrees. When you have those 3 films and you're kind of looking at it, at that point, you can evaluate, do we have any carious lesions? Do we have any defective restorations, at least radiographically from the crown standpoint? When we look kind of at the pararadicular structures, the big thing that we're looking for is just, is there a radiolucency associated with the tip of the root of the tooth? Secondarily, if we don't see a radiolucency, we're looking at the PDL space around there. And is that widened or does it look kind of thickened in response to other roots of adjacent teeth? Those are kind of the big things that we want to look at as far as, whether there's a kind of a possible endodontic problem. And when you start to get into kind of more detailed kind of things, you get into evaluating kind of actually how whether there's any type of resorptive area present, and that could be internal or external. You're also evaluating secondary structures to make sure that, of course, we have odontogenic problems, but we also have non-odontogenic problems. That could be, some type of salivary gland issue. It can be some type of, bony issue that isn't related to a tooth problem, but because it's in that region, might show up on an x-ray. And that would be kind of more pathological problems.
And so these x-rays that we're taking, that's happening when someone is in pain, not necessarily like they've come for their hygiene appointment and we would be taking let's say an FMX or a bite wing series. Like we'd start taking those 3 x-rays when they were like, there's something wrong. Okay. I just wanted to clarify because every hygienist that might have heard a little bit of it was like, this doctor's crazy. You think I'm taking 3 x-rays on all of these patients?
Yeah. We have plenty of time for that in our appointment.
Well, that's the other thing, and because I know a lot of the stuff that y'all do is, a lot of hygienists are, paid on production. And so a lot of the things that we're actually talking about, there are dental codes. I think it's D0460, which is for diagnostic testing. So if he hadn't really gone over some of these things, you can do all this stuff. And in a busy dental practice, to me, it makes sense for y'all to be thoroughly involved in this process because the doctor's jumping from patient to patient to patient. And if you're able to narrow things down and help him out, you can come in and say, well, this is what we've got. We've got a tooth that's percussion sensitive here. It's non-responsive to cold. Necessarily you're not coming up and saying the diagnosis is it's a necrotic tooth, but you're basically doing 80% to 90% of the work for him. And it's an invaluable service you can actually bill for that. And like I say, you can help speed up the process. And the truth of the matter is, I actually think most of the patients really come because of y'all. And they're going to be they're more open to tell you about their problems than they are the dentist who comes in and spends, 10 or 15 minutes with them. That's just my personal opinion.
This is, I think, the flip side of that. It's always, and this is a good digression before we move back into it, but I think patients like to tell a doctor versus a hygienist very different things. And they'll tell us very specific things, but then hygienists will complain all the time. Like the doctor walks in and they're like, oh yeah, I just had a heart attack and oh, I have a pacemaker. And we're like, hello, didn't we just do a medical history review? But then you'll leave the room and they'll be like, what are they trying to sell us on? Like, why do I really need that procedure? So it's very different information. And I think that's why we always need to be working together, because patients, it's like that mom-dad situation. Go tell your dad, go ask your mom.
And I'm on a different, being an endodontist, people open up to me in a different way than they do their general dentist. So I actually hear most of the time, I go because of the hygienist. The dentist is nice, but it's actually, like I say, it's a different kind of thing. And a lot of times what I find is they actually, as far as the trust goes, they really trust y'all a lot more than they do the dentist. And I think that's just because they see y'all on a frequent basis. You get to know them, you get to know what's going on in their family life. And that really helps out as far as kind of going. But I know what you're saying. I've been there before. I'm like, what do you mean? It's, you're going in tomorrow for, a triple bypass. That would have been important to know before we got started.
They're so crazy. So I want to, if we could just take a next step I would love to talk about etiology of endo concerns, maybe even looking at bacteria versus trauma. Is morphology even a consideration? And then we would like to know what a basic root canal procedure entails. Like, what does that look like? And then finish it up with, how do we communicate that to our patients? Like, what would you like for us to be discussing as the endodontist, if a hygienist could kind of prep them for what's to come?
Like you said, the etiology of any type of endodontic problem is always bacteria. And so if you ever get into any type of endodontic circle, there's a kind of the gold standard paper that endodontics was based on was a paper from this guy named Takahashi. And what he actually did was they had these germ-free kind of rats where basically they would literally just drill holes in the teeth, hit the pulp. But because there was no bacteria in these, animals, they never developed any problem. It would actually just repair. But when you had these little rats that had bacteria, and you ended up drilling a hole and hitting the pulp, every time the pulp ended up dying and becoming abscess tooth. So bacteria are the cause of it. Overall, of course, in the oral cavity, there's over 300 species that have been isolated. It always starts with, some type of, bacteria such as strep mutans, secreting an acid and creating a, kind of decay on the tooth. The actual process develops as the bacteria kind of begin to kind of, for all intents and purposes, erode away into the dentin of the tooth. Of course, the dentinal tubules, they have fluid in there. The fluid actually is kind of a mechanism to kind of prevent the bacteria from getting in there. So if you imagine turning on the faucet, the water's coming out. Well, the fluid flow is to prevent bacteria from coming in. Eventually, though, the bacteria can move through there. There are little cells called odontoblasts, and what ends up happening is the bacteria secrete certain things such as endotoxins, which the endotoxins eventually cause an inflammatory response. So imagine if you got a little splinter up underneath your skin, well, of course, you'd have inflammatory cells. So what happens is when these little endotoxins and the bacteria start to travel through the actual dentinal tubules, they get closer and closer to the pulp tissue. And we're sending our inflammatory cells to kind of stop these, but eventually they get overwhelmed. And so as they get overwhelmed, the first step in the process is they will kill the odontoblast, move past that, and they actually start to get into the pulp. And so you will have the pulp tissue kind of trying to wall it off in a way. Some of the original theories, people used to call it the strangulation theory, because they viewed the tooth like a head, where if you got hit in the head really bad, it would swell up, and the swelling would cause pressure, and it would cut off the blood supply, and the patient would die. So same kind of thing for the tooth. One of the first theories for why the actual pulp ended up dying was, well, you've got a closed chamber. If you have swelling in the tooth, it would cut off the blood supply, and same thing would happen. That actually has been disproven. We do know that there are some lymphatics in the tooth that can provide for collateral circulation. But in a sense, what ends up happening is the bacteria just overwhelm a portion of the nerve, and that portion will just then become necrotic. So once that tissue becomes necrotic, it then kind of starts a cascading effect where, like I say, you still have to either remove the bacteria. In some of the early stages, that's where you can do such as, say a carious lesion that actually enters the pulp. You could sometimes remove the decay. You can even remove some of the diseased pulp tissue and do a direct pulp cap, or, kind of put a medicament down to see if the nerve of the tooth would respond. Sometimes it will with some of the newer materials such as MTA and the biodentin. You can get fairly good success rates with pulp capping. But if the pulp tissue is inflamed further down through it, and it's a mature tooth, the odds of it totally recovering it are very poor. And so in those situations, the root canal therapy is kind of the way to go. The procedure itself, I always try to kind of keep things simple to the patient. And I basically just say, you've got an infection in the tooth. You've got diseased tissue in there. There's no more blood supply, or there's weakened blood supply. So your body's immune system can't fix the problem. So all we're physically going to do, if you imagine the tooth is just like a ballpoint pen, it's hollow. And we're basically going to drill a hole, and we're going to get into that hollow area, and that's where that diseased tissue is. And then literally what I say is you file your nails. We take files to the inside of the tooth. We literally file out all of the bad stuff, and then we fill it up with a little plastic filling. And that's the dumbed down kind of, patient version. The physical process of what we're trying to do is to actually remove any pulpal tissue that's diseased. We want to disinfect the tooth as much as we can. You can never sterilize the inside of the tooth. So that's kind of the catch with what we do, and that is why you actually obturate the tooth afterwards. So the physical process, literally, you're going to access the tooth, you're going to enter the pulp chamber. Once you do, typically you have to get a measurement or a length on the actual root of the tooth. So most people use little files. I typically start with either an 8 or a 10 file. We actually put that in the canal, and as we they call it a watch winding motion, but you're kind of just going in a reciprocating motion back and forth, and you're able to kind of work this file down the root of the tooth. You have a machine called an apex locator that actually, for all intents and purposes, bounce frequencies off the inside of the tooth. Once it gets to the periodontal ligament, it allows you to know that you're at the apex of the tooth, and will literally flatline out. So you know that your instrumentation procedure should go from that millimeter that you actually record from top to bottom. After that, you literally create what's called a glide path. So you're going to work smaller files into bigger files. And typically, I like to work up to a size 15 hand file. And then typically, you take rotary files in there, and you use a lot of hypochlorite while you're doing that. Hypochlorite, of course, kills any bacteria. It also dissolves any tissue in the tooth. So you're flushing it out while you're doing the procedure. You take rotary NiTi files in there. It allows you to kind of grind out the bulk of the tissue. It also allows you to grind out kind of circumferentially some of the dentin as well, because we know that the bacteria have impregnated a certain amount of the dentinal tubules. Once we do that, we basically create a tapered shape that facilitates the obturation of the tooth. The obturation, you can do it kind of a couple different ways. Most people have a tapered gutta percha point, which is literally just a kind of a rubber filling. Most of it actually is a zinc oxide that's mixed with this gutta percha or natural rubber. You actually fit this cone that is literally matches the exact taper that you've just prepared. You then use a cement or a sealer after you dry the tooth out, and you literally put this in there, and you kind of pack everything down so it fills every little nook and cranny. There's different ways you can obturate it, but in a nutshell, you're literally putting in a gutta percha point with sealer around it and kind of, searing that off at the canal orifice.
What about like accessory canals?
For the most part, that is how you obturate it when you have it depends on the type of technique that you do. Some people use a technique, kind of the gold standard is cold lateral, where all you're literally doing is physically putting in cone after cone after cone and then cutting it off. You don't really fill a lot of lateral canals with that, just because it's just kind of a physical process of wedging things in there. The technique that most endodontists use is something that's called, warm vertical or a continuous wave technique. you're using that matching tapered gutta percha point, and then literally what you're doing is you're heating a plugger and diving it down into the actual gutta percha. So the gutta percha doesn't have anywhere to go. So if there's a apical ramification, it's heated up and it's forced into that area. And so then you pull out your heated gutta percha or your heated plugger. You then kind of condense that, and then you have a thermoplasticized machine that basically kind of squirts kind of molten rubber into the tooth that you can kind of pack it down into every little nook and cranny. It's kind of a neat little technique. It's easy to do once you learn it, but like I say, most of the time it's just endodontists that actually use that technique. Down there at the clinic that you've seen, we use kind of a variation. There's a single cone where basically we're using a kind of a sealer to fill any voids. That sealer that we use over there is very hydrophilic. So if there are any little, kind of accessory canals, a lot of times it can flow into that as well.
Wow, I'm learning so much right now. Andrew, did you have any questions before I asked another one?
No, I'm excited to go into that communications thing, because that's
my one question is before we move into that is retreats. Of course, then we can tackle how do we have that conversation with patients, but why would a root canal need to be retreated sometimes? And what happens when, well, I'll tackle that. Let's talk about retreatment. Retreatment.
Well, so the one thing, and I'll emphasize this, from the endodontic standpoint, you will see a lot of root canal failures. And depending on where you practice in the United States, some of my buddies say that half of their practice is literally just redoing other people's root canals. Up in the upstate of South Carolina, it maybe was 20% of what I did. And statistically speaking, overall, if the root canal is done properly, success rates are in the 90 to 95% range. But I always approached it by saying, first off, to the patient, if I'm doing a procedure, I'm like, okay, this is what the success rates are. You got to understand, if I do it on 100 people, 5 of them, it doesn't work. And it doesn't matter if you do it perfectly. Sometimes there's still an issue. The primary issue really kind of goes down to bacteria, and that really goes to the fact that you cannot sterilize the inside of the tooth. When you talk about retreats, though, really you're looking at, was there a problem with the original root canal? And so that can happen a couple different ways. Either they did not find everything that they were supposed to find, and that's really where were they using a surgical microscope to actually do the procedure? If it's a lower molar, did they find, sometimes they can have anywhere from 3 to 4 to 5 to even 6 canals. So if you're hearing someone talking about doing a root canal on some of these lower molars and they're only finding 3 canals every time that they do it, well, odds are they're probably missing some, statistically speaking. So missing kind of anatomy in the tooth is a huge thing. The other thing that plays an important role in whether you need to retreat a tooth is bacterial contamination. There was a real famous article by Martin Trope where he actually looked at all these root canals that were done, and coronal leakage was one of the major things that played into whether you had to retreat these things or not. And he kind of broke everything down into situations where you had a perfect looking root canal, but they didn't put a filling on it for like a year. Well, of course, that thing leaked. Even though the root canal looked great, it got reinfected. They had situations where people did a horrible looking root canal, but it had an awesome restoration that was tight, perfect, didn't leak. Well, believe it or not, that actually has, statistically speaking, better success than the opposite kind of on the spectrum. So what they found is that it's not just doing a good root canal, but it's really kind of the general dentist making sure that the top portion of the tooth is sealed so that you don't get an ingress of bacteria recontaminating everything. But really the anatomy is the main thing as far as making sure you get what you can when you're going in there. And then, like I say, coronal leakage is a huge thing. So when you see patients who have had a root canal and they break the tooth and they're like, well, it's not bothering me, I'll just come in a few months. That's you've got to emphasize, no, we need to get something to seal this up so that we don't create a problem and you end up having to redo the root canal down the road.
That's a good tip. So the communication aspect, like from a hygienist that's about to either, well, Andrew, this was more your thing. How would you like to present that?
My dentist diagnosed that there's, pulp necrosis or irreversible pulpitis, whatever it is. Now we're going to send them off to the specialist. Then, as Michelle mentioned earlier, they always turn and be like, okay, Andrew, I trust you. I've been working with you now for 30 minutes or 45 minutes of this appointment. what can I expect? And so what I was hoping to get from you, doctor, was what kind of communication would you like us to have with the patients to kind of help prepare them for their appointment with you?
So first off, they always need to eat before the appointment. I don't know how many times people show up and they're diabetic and they're like, well, I just figured you're going to be knocking me out or something. And you're like, no. This is just like you're going to see someone for a normal restoration. But yeah, first off, they've got to do everything that they normally would, eat, have a good meal in the morning before they show up in the appointment. The actual procedure itself, normally I say, is just kind of like getting a filling. There's some differences because it's going to be a lot longer appointment. On average, we typically block out, in my practice, we block out an hour and a half. The actual treatment time for me was really only about 40 to 50 minutes. But we always would, make sure we'd bring them in. We had an hour and a half blocked out for them. We would go over any questions or concerns that they would have. And then we would talk about the actual procedure before we got started. For y'all, basically, I would say, okay, it's going to be a little bit different. They're going to numb you a lot. So if you just had just a normal restoration, they might do one shot. Say he's going to numb you like you were never numbed before so that you don't feel a thing because he wants to make this the most pleasant, procedure for you. And to be quite frank, you've got to have a deeper level of anesthesia to do this procedure than some of the other things that you run into. The flip of the coin with that as well is that most of these teeth are inflamed, and inflammation, as you know, makes things drastically different as far as trying to get somebody numb. So that plays into it. So first things you're going to say, yep, it's going to be a long procedure. He's going to numb you a lot. The big thing that y'all need to tell them is he's going to use a contraption called the dental dam. And I don't know if y'all, use that. You probably don't as far as, being a hygienist. But he's going to put this little dental dam right over your tooth. It's going to isolate just that one tooth. That's really important for people who are claustrophobic. So when they get there, they're not just wigged out. Most people, they already look like a deer in the headlights when they're coming in. It's hard for someone to meet somebody. And then guess what? We get to do an hour procedure on you. It's kind of a little bit overwhelming from their standpoint. But if you did have a dental dam, you got to show them what it actually looks like, how it actually fits over the tooth. That really helps kind of calm people. I always say you've got to understand this actually helps you. Once you get it on, we're keeping everything on our side, and all you got to do is swallow, and all you're going to have is just your saliva on the other side. And a lot of people like that because nobody really likes kind of the water spray or stuff getting in their mouth. They got to swallow, and it actually, slows down the actual treatment time. The actual procedure, normally I say you'll always feel us working in the tooth. It's kind of an odd sensation, just a little bit of some pushing and pulling in the tooth as the little rotary files go in there. But literally, if they can do a filling or a crown, anything like that, it won't be bad. Like I say, besides the time duration, the actual physical process is not that bad. Afterwards, we always emphasize that they will have discomfort. You always kind of want to prepare somebody for the worst. And then if it works out, most of the time they usually don't have, but just minimal pain afterwards. But I always like to say, okay, you will have some discomfort. It's like you've got a bruise around the tooth. If you bite or put pressure on it, it's going to bother you. Most of the time we do adjust their bite so that they're not hitting hard on the tooth if they came in a situation where there was pressure sensitivity on the tooth. I use a lot of little sayings, and I say, well, if you sprained your ankle, you wouldn't go running, would you? And they're like, no. Well, same kind of thing. You bruise your tooth, lay off it for a few days, allow things to kind of recover.
Are there any key words or key phrases that you would not want us to say ever?
The biggest thing that I think is that patients sometimes latch on to things. And so I have found, especially when you're talking, like you said, about retreatments, you got to be real careful because sometimes you can do everything right. And if someone were to say, well, it looks like he missed a nerve, that's bad. And so unless you're 100% certain that there was, an obvious treatment problem, I would be real careful with what I say for that, because not only, we don't know the circumstance. Sometimes you're meeting someone for the first time and they're really difficult to work on. So you got to factor into that. We just don't know the circumstances. So in those situations, if a patient hears something, I've had, unfortunately I've had some dentists say that and they were wrong. It didn't matter if I had a cone beam of the tooth and I showed the patient, in the patient's mind, I had done something wrong. And they're like, well, you missed a canal. I didn't miss anything. You know, unfortunately, it was misinformation that was given. So I would say I'd be very careful on criticizing other people's work. I think you always got to, understand that you always got to be truthful with the patient. You can never lie, but there's always way to say, well, I'm not sure. There are certain reasons for why sometimes things fail. There is not a 100% success rate. So unfortunately, you can do everything right and it not work. And that's just the way the cookie crumbles sometimes. But I would say don't get boxed into a particular thing and just say, well, these are the facts. This is what we're dealing with. We're going to send you to a specialist or have our general dentist take care of it, and allow them to address the concern at that point.
And just to close up a little bit, because I found this really interesting when I asked you one time about sinus inflammation and how often people will get a root canal, and really it's just sinus inflammation. Can we touch a little bit on when patients have similar pain in their teeth, but really it's not endo?
So when you're looking at odontogenic versus non-odontogenic, non-odontogenic pain can include a whole bunch of different things. So when you're talking about a sinus inflammation, basically you're talking about inflammatory disorders. So if you're up here in the upstate of South Carolina, like I am right now, you've got pollen kicking everywhere. I mean, I think this is one of the number one places in America for having, allergies. So any type of inflammation of the sinus can mimic a tooth problem. Typically what you would see in those situations is patient come in with a dull fullness in their face. Usually it's unilateral, although it can be bilateral as well. If you were to do an exam, what you find is that there might be generalized percussion sensitivity for the posterior maxillary teeth. All those teeth that are up in the maxillary sinus, if the sinus is inflamed and the roots of the teeth go up into the sinus, well, of course, it can kind of cause some symptoms with that. So you might have some generalized percussion sensitivity, maybe some bite sensitivity. The catch is that when you would go in and do your cold test, everything would test normal. So in those kind of situations, that's when possibly getting a panoramic or a cone beam x-ray where you could actually see some thickening of the sinus lining or some fullness in that sinus on the radiograph would help you kind of determine that it might be that. Other things that you run into, a big thing that y'all probably see is just myofascial pain disorders. Whenever you've got somebody who is overworking a muscle, you tend to have basically the muscle go into a protective state. A lot of times that can be related to posture. Sometimes it can be related to bite issues. Sometimes it can just be stress where people, they take it out on their teeth where they brux or grind. As a result, the muscles go into spasms and it creates kind of diffuse pain in that region. A lot of times with something like myofascial pain, you'll have kind of trigger points. So when you're doing your intraoral and extraoral exam, you can palpate the muscles of mastication. You can palpate some of those cervical neck muscles. And a lot of times if you kind of palpate a certain area where that trigger point is, it'll elicit the pain, put pressure on it, and the patient will say, oh my God, that's exactly the pain that I've been feeling. Those are fairly cool to diagnose, and you're providing a massive service to the patient. Most of the time, the treatment for those kind of things, is palliative in the beginning, soft diet, NSAIDs, moist heat, kind of the common sense things on how you would approach it. Sometimes you can get a physician involved or, have your doctor, talk about putting them on some type of muscle relaxant. You actually can consider some low-dose antidepressants such as Elavil or something like that, and because they have some muscle-relaxing properties. And then, like I say, Valium is always a good thing as well, or cyclobenzaprine as far as the muscle relaxants on that avenue. Other things that you can think of, you had said something about referred pain before. Whenever somebody comes in and is having referred pain, especially to the lower jaw, if they're starting to complain of any type of arm pain as well, obviously cardiac pain would be something that you would consider. So that's few and far between, but it can happen. In those kind of situations, you have kind of afferent neurons kind of firing from the heart. And they basically what happens is they kind of get mixed up on the track. And so then when the efferent neurons go out of the spinal cord, they refer the pain back to kind of the wrong place. So then they'll have kind of pain in that lower jaw. The patient will swear that they've got something going on. Most of the time, those are a little easier to kind of figure out from the standpoint of usually they'll have exertional problems as well that kind of tie into that when they have the pain. But that's something that I would think of. I would imagine y'all probably see a lot of people who have migraines. That's kind of a big thing in today's world that we deal with. They can sometimes mimic tooth pain as far as just kind of giving kind of a dull ache in the, kind of in that region. Trying to think of anything else.
It's a good list. Well, this was great. I think that this was a good starter. And if we have any listeners who have follow-up questions, we could definitely either go in depth in another podcast, or maybe they can send any questions to you if that would be okay with you.
Yes, go right ahead. I think y'all got email, just ravenelt@musc.edu. Any questions you have, just shoot them my way. And like I say, when you ask me about doing this, it's interesting to find out that, some hygienists don't do this kind of stuff. And to me, it makes total sense. Down there at the medical university, one of the nice things is that if I run into a patient that I'm having a hard time figuring out what's going on, I always have a backup where I can go get somebody else to take a look. In a solo practice or even a group practice, you have that ability. But say, if you have someone look at something before you and you can sit there and walk in and say, well, I think it might be this tooth, or I don't think it's a tooth-related thing because things are, testing normal. That's always kind of good to kind of get a second opinion. And that's what you're providing, and you're helping narrow things down for the dentist. I think everybody's going to win in that situation.
Well, this was great and extremely informative. I work with you and I didn't even know a lot of these things. So this was great. Thank you again for taking the time and coming on the podcast. We really do appreciate it.
Yeah, thank you.
Yeah, no problem.
Well, I hope that we did not steer you wrong and you learned a lot and it wasn't boring. I was really fascinated by, just kind of relearning the etiology and everything behind endo. I personally have never assisted or seen much with endo, even though they're the room next to me. I haven't really seen much. So we hope you guys enjoyed that episode with Dr. Ravenel.
So we're going to be hanging out at ADHA in Louisville, here in just a couple weeks. So if you guys wanted a chance to meet up with us, please message us, let us know. You can go through all of our regular Facebooky, Instagrammy, Tweeters, and message us and let us know. I think we're going to try and do some meet and greets also at some booths. So if there's a particular product that we have mentioned on the podcast that you wanted to learn more about, let us know and we will go introduce you to them and show you some things that we love. And all those things that he talked about earlier, like the Facebooks and the Tweeters, you can find us at Instagram or Facebook at A Tale of Two Hygienists. You can also email us at ataleoftwohygienist@gmail.com or one of us directly, Michelle at ataleoftwohygienist.com or Andrew at ataleoftwohygienist.com. And we would love for you guys to keep sending us messages, keep direct messaging us. We appreciate your iTunes reviews or ratings. Anything would be fantastic. And continue to share and also give our guests some love. So if you've really learned something from them, write it on Facebook, share it on Instagram, do something to show them how much you appreciate them, because they are coming on this podcast just for the love of disseminating the correct information. And we want to make sure that they know how much we appreciate them. So we thank you guys for sticking around for another week. And if you are going to be at ADHA, we would love to see you. Anything else, Andrew? I think that's it. Bye, everyone.
Bye, y'all.